Facial paralysis is lack of any motion in the face. Most patients present with one side of their face that's not moving, and that can be due to a variety of causes. Tumors, often benign but could be malignant in the brain, such as acoustic neuroma or schwannoma. You can have paralysis from arteriovenous malformation in the brain. You can have paralysis from parotid cancer, which is a type of salivary gland in your cheek where the facial nerve is running through that. And you can also have paralysis from unknown causes, often called Bell's palsy, thought to originate from a virus. Can happen after pregnancy, it can happen after Lyme disease. So there are a variety of causes of facial paralysis, but it's a devastating condition not only because of the obvious cosmetic change of not being able to move your face and having unrestricted motion of the unaffected side, but it has severe functional consequences. One is potential loss of your vision. You can lose oral competence, meaning that when you're drinking or eating, liquid or food can fall out of your mouth. It can change your speech, and for many people that's a life-changing situation, not to mention the social stigma. Most people in the public don't know about it, so these patients go through a lot. So if somebody's coming in already with facial paralysis, one of the key considerations is how long they've had the paralysis for. If the patient sees us less than 2 years, I would usually do dual nerve transfers. That involves a nerve to masseter transfer and a mini hypoglossal nerve transfer. I simply combined the two and targeted these nerves to specific parts of the face. You can have a pretty decent outcome with just the nerve transfers. Usually though, for the best outcomes, we'll do things like cross-face nerve grafting, where you're taking nerve grafts from the normal side of the face, tunneling them to the paralyzed side or weakened side, and that allows you to get spontaneous motion where you don't have to retrain yourself to learn how to smile. You just smile automatically. In patients with very long-standing facial paralysis, those muscles, if they've been asleep for more than 2 years, are unlikely to come back, and they've probably turned to scar. At that point, we need to transplant muscles from other parts of the body to replace the muscles that are not there anymore. Usually we'll do that with a muscle from the inner thigh called the gracilis. So there are a variety of procedures and smaller procedures around the eye. Facial reanimation is a process usually made up of several procedures. The day of surgery for reanimating the face using nerve transfers in particular, you'll arrive at the registration desk, you'll meet the anesthesiologist, and of course you'll meet me. We'll do our markings, we'll go over and finalize any specific goals that you have. I want to know very clearly anything you want to emphasize to me that's important. We'll confirm we're on the same page, and then we go to the operating room, you'll be put to sleep, and before you know it, as if time didn't pass, you'll wake up. These can be overnight procedures, so you're usually discharged the next day. There's not a whole lot of restriction. Sometimes you'll be asked to be on a soft diet for a week, but mostly you're a bit wounded and you just have to wait for your body to heal. We'll be seeing you every week, and we encourage you to call us anytime for any question, but we'll hold your hand step by step. Outcomes from facial paralysis vary significantly, and that just depends on the specific condition, how long the nerve has been out, and the specific procedure we're doing. But if somebody has total facial paralysis and we're doing nerve transfers, greater than 95% of the time we can restore smile and reasonable eye closure and motion to the face. It's never going to be 100% normal, and once the facial nerve is out, it's unlikely that it'll ever be 100% normal. Well, my hope for the future is to use drugs and techniques that will ensure more powerful and predictable regrowth of nerves, because the procedure itself is really rewiring the nerves and laying down all the electrical wiring. The rest is up to the specific patient's nerve's ability to regrow and to regrow to the right target. There's no technology currently that we can tell a specific nerve or axon to grow exactly there to close the eye, or exactly that muscle to lower the lower lip. So there is some variability there that's out of our control. I'd also love a technology that would prevent degeneration of a nerve once you cut it. So for example, once you cut the facial nerve, say in a parotidectomy for salivary gland cancer, even if you sewed the nerve right back together again, nothing's going to work. You have to wait for that nerve to regrow from the cut point all the way to the muscle. So when we're reconstructing nerves, patients basically waiting months before they see any sign of nerve recovery. And so it would be nice to have a much shorter recovery, and I think through future technologies in drug development, we may be able to get there.